thing going? Right, that's up and going. Okay, so, sorry, I'm freezing, everyone. I'm sure everyone that's in South Africa can also relate. Thanks so much for joining us on another Wednesday webinar that happens to be on a Thursday this time, because of the exciting guests that we have with us tonight. Unfortunately, couldn't make yesterday, so we were happy to move it to a Thursday and to have them on board. So as many of you might know, tonight we're discussing Ehlers-Danlos Syndrome, and we have a lot of patients in South Africa that have been impacted with EDS. I think many of them really being diagnosed way further down the line after numerous surgeries and all sorts of clinical issues, and really only getting diagnosed sometimes a decade or two later. I know Corné is on the line, and I know Corné is one such patient who had numerous surgeries prior to getting a diagnosis, and she shared her story at our recent conference, and Corné mentioned that had they known, they wouldn't have done a lot of the surgeries that they have done. So she sits in a position where she battles every day because of the lack of a diagnosis or an appropriate diagnosis at the time. So we're really excited to have both Lara Bloom and Hakim on the call with us this evening. So Lara is someone I've met a few times in our travels across the world, and Lara is the executive director of the International Ehlers-Danlos Society. And I mean, Lara is just an exceptional woman, and anybody who's met her will see that she always has a camera. She is an exceptional vlogger, but also a really good advocate for Ehlers-Danlos syndrome, and I think has really single-handedly raised the profile of Ehlers-Danlos across the world. So, so Lara, and then Dr. Alan Hakim, who's a rheumatologist, and he is an acute physician and rheumatologist with a special interest in heritable disorders of connective tissue, such as EDS, and we're very, very excited to hear what they have to say this evening. So without any further ado, I'm going to hand over to Lara.
Thanks so much, Kay, and thank you for all your very kind words. We're delighted to be speaking to everyone today. We've been following the work of your organisation for a few years, and we're really keen to try and do an event in South Africa one day. So we're going to talk about that today and talk through the work that we're doing as an organisation and leave some time for questions. So Alan, could you start sharing the screen? Thank you. It's always this little moment between transitioning between the two.
Perfect. Should be able to see the full screen now.
Indeed, thank you. Okay, if you could move to the first slide then, please. Okay, so I'm just going to take the time to just briefly run over how the Ehlers-Danlos Society is formed. We launched officially in 2016, and we actually were born out of what was the Ehlers-Danlos National Foundation, which was the US organization up until that point. And we're governed, you can see here, by two boards. Our strategy and governance is run by our board of directors. And it was very, very important for us to really have a very strong medical and scientific board at the center of everything we were doing in terms of research and content for our events, both educational, scientific, and things for patient support. So we've really got these two very, very strong bodies that are governing what we do and helping us to shape the work that we deliver to our community. Next slide, please.
I am trying. There we are, sorry.
There it is, no problem. I think one of the most important things that we do is facilitate the work of the international consortium. Prior to 2016, there were a lot of amazing experts, but they were kind of working in silos around the world, and there wasn't this collaborative effort coming together as often as it needed to. At the end of 2014, between EDS UK, which is where I was previously working, and what was EDNF, the US organization, we came together and realized that the strongest thing that we could do was reclassify the diagnostic criteria for EDS and develop management and care guidelines for the first time. And so there was this effort to bring these experts together. And by the time we got to 2015, we realized that this was actually a whole job in itself, ensuring that everyone was talking to each other, working together, and making sure there wasn't another 20-year gap before the next criteria was evaluated. So we realized that this needed to be a global organization, and our main mission was to support the work and facilitate the work that this consortium was doing. Next slide, please. There we go. And so you can see, I'll talk through how we're structured here. We have a steering committee, which is driving much of what the kind of are for the group. And we then have the classical committee, the hypermobile EDS and HSD committee, vascular committee, and the rarer types committee. And all of the chairs from those committee, plus myself, are what are the people that make up the steering committee. Next slide, please. We also have all of these working groups, and you can see here the two different colors. So the blue ones are the ones that we added following the 2017 paper, because we realized that there were real gaps. So for example, you can see there, the pain and psychological group was previously one group, and we've now separated that because we really can see that there's an importance to focus on them individually. We've added a group on pelvic floor issues. The previous physiotherapy group has now been renamed to allied health. We've added a group focused on hematology. So we know that there's some issues with blood and EDS, but we don't really know what that is. So we really wanted to task some people to try and find the answers around bruising and issues such as that. We've also added on skin manifestations and nutrition from the general GI. I think creating gap in the 2017 publication is in pediatrics, and we don't have enough evidence and research out there. We need to ensure that this happens, and the best way of doing that was to develop this working group, and it's quite a large working group with people from all over the world on it, and we're really excited to see what they're going to produce over the next few years. Next slide, please. So after the 2017 publication was out, we didn't then stop. We actually added even more tasks for this group to do. There's about 150 people now in the consortium, so it's really amazing seeing everyone come together. And we genuinely have weekly people trying to then to add themselves to the consortium. So there's a real want globally for people to be involved with this effort. So what we have people working on from now till 2020, Rome is working on annual literature reviews and ensuring that that's published. And even if that publication is just on our website, we're making sure it's out there for people to see. We're also developing something called common data elements, which is essentially language, no matter where they are in the use language, whether it be research or in our registry. So if you're using to measure things, as to describe things, it's the same tools no matter where you are. That's quite a long process, and we don't see that being until June 2021. We're working with the Comorbidity Coalition on developing a clinical pathway for both EDS and HSD for diagnosis and management care. Again, I think we're going to have to look at this and split up the world a little bit, because we know that locally people have different issues. And that's where it really helps us working with organizations such as Rare Diseases South Africa to find out pathway work for South Africa. You know, what would we need to change? Does it work in Europe? Does it work in the US? And really trying to understand what we need to do. So that again is going to be a long process, and one that we really need to ensure we're doing right. One thing that we've immediately to answer is, what are our research priorities? So when we people that come to us and say, I'd like to fund some research, we can actually say, right, well, these are the priorities where we need to focus. And that's really interesting. We're putting together our research roadmap at the moment. Next slide, please. I also mentioned just now our Comorbidity Coalition, and you can see the people who make up that group. Comorbidity Coalition was created just over a year ago off the back of the PCORI grant. And the PCORI grant was tasked for us to bring together other patient organizations, other patient experts who could come together and really think what research priorities were and what direction we should go in to best serve all the comorbidities that come with living with EDS and HSD. So in the first year, that's what we worked on. We worked priorities. And I'm pleased to say that almost all the studies have been very active in trying to get funding for those, and I think they'll be successful. And now for 2019 on helping develop these pathways. And as I said, we foresee a 2 to 3 year project. Next slide, please. We've been doing a lot to raise awareness. As you may have seen following us on social media, we realized that, we really need to reach people because, there were a couple of things against us at the beginning. The first one being people thought we were just a US organization. We came out of what was EDNF. Most of the people on our social media were from the US or from the UK, but we really wanted people to start to understand we want to represent anyone and everyone living with these conditions, no matter where you are around the world. Next slide, please. There we go. You can start to see the impact on in the work that we've been doing and how that's kind of translating onto social media and the web. So on Facebook in 2016, when we first launched, there were 25,000 people following us. There's now, in fact, nearly 78,000 people. On Twitter, 2,000 people. On Instagram, we had 0 people following us. And in 2019, we have, I think, now 24,000 people. So that's increased massively, even since we just did this slide. On our website, we were having on average 20,000 unique visitors a month visiting us. And that has now jumped to nearly 300,000 people individually coming to our website every single month to access this information. We have our forum on Inspire, which in 2016 had 4,000 people on it. And we now have nearly 71,000. So these figures really show how much we are spreading. We're getting bigger every day. And we really want to hear from the communities themselves the best way that we can support you and reach out and change things for you. Next slide, please. As you can see here, we've been speaking at a lot of different events. I think it's really important for us that we collaborate with as many different organizations as possible. So we're not just talking at EDS specific conferences. You can see here we've spoken at Global Genes Dysautonomia Conference. I spoke at the Royal College of Pediatrics and Child Health about the importance of mental health as well as physical health when living with a chronic condition. I also spoke at the EU in Brussels about the importance of patient engagement. And getting across on these different platforms and levels is allowing the term and the concept of EDS and HSD reaching people that previously it had not done before. Next slide, please. As I said, we really want to get out there as much as we can. We have been doing conferences all over the world since we launched. I, in fact, did come to South Africa. I think it was back in 2015 now, and we were at a rare disease conference there. But we didn't have our own EDS conference, and that's what we're really working towards. We have been able to now do a European conference every year, one in the US, and in November we're going to be going to Tokyo. Last year we were in Australia, and like I said, if we can see the opportunities and we can warrant the funding to get there, then we will get there. We really want to access rural areas, places that people would never think we would go to, Asia, India, everywhere in between. We just need to show that we have the community there, and then that we can explain the funding that it's taken to get to those people. And I think we're learning as time goes on that that's really important to have that process in place, which is one of the reasons why we're talking to you all today, so that we can try and identify the need that we have in South Africa, and also try and understand where it would make sense for us to come and do a conference if we did. Next slide, please. Something that you can do to help us is, if you do have medical professionals that are helping you live with your EDS, is ask them to join our medical professionals directory. It's really quick to do, it's free to do. Because of GDPR and HIPAA, and I'm sure there's other laws in South Africa as well, we can't put those details on there without the professional themselves entering it. But it's on our website, and we really would encourage you to point that to the people taking care of you, whether that's physiotherapists, OT, podiatrists, cardiologists, GI, anything at all. Please make sure that they're on that directory, because that's how other people living with this find out that there are people willing to treat EDS. You know, I always say there's actually no such thing as an EDS expert. All it is someone in their discipline being willing to learn and treat people with EDS. And that's what it takes. So we need to build up that rather than EDS experts, that they don't exist. Next slide, please. Something you may well have heard of as well is our recent registry launch, our global registry. And I think we've got a poll running, which is asking people, are you actually on the registry? Now, we hear time and time again, EDS is so much more prevalent than we think, but we need to prove it. We need people to raise their hand and say, I am living with this. And I think that that's essential. And I think people don't realize how much they can do themselves. Again, it's free. It will take you about 15 minutes. And it also then enables you to be on our research profile so that if we're doing research studies, we can reach out to you and invite you to take part of those. So please, as soon as this webinar is finished, make sure you go and join the registry if you haven't done already. Another thing that we've been talking a lot about is our hEDS study, the Hypermobile Ehlers-Danlos genetic evaluation. Just over a year ago, we were very, very lucky to be donated $1 million, which was then matched. And we now have $2 million looking into this. And that was really a huge first for EDS generally, let alone our organization. There'd never been that level of funding available to really try and explore and do this research. So with that, we're doing 1,000 whole genome sequencing from people all over the world. And we're trying to really find what the genetic causes are. And even if we don't have a straight answer of 1 gene or 5 genes, that in itself will be an answer, because so far this hasn't been studied at all to this level. And it's bringing people together for the first time ever. Again, trying to prevent everyone working in silos. We're going to create a hEDS repository so that this data from all over the world can come together for the first time. Next slide, please. Another thing that we have been talking a lot about is EDS echo. And we wanted to ask, has anyone here heard of EDS echo? And Dr. Hakim's going to talk in a lot more detail about what this is. But essentially what we're trying to do is by 2022, create 1,000 new people willing to treat and manage people living with EDS and HSD. And you're going to hear a lot more about that shortly. But let us know if you've heard of EDS echo, or indeed if your doctor is aware of it. Next slide, please. Collaboration really is at the heart of everything that we are doing, whether it's collaborating with other medical professionals, other patient organizations, and indeed other patients. And we really think that that is the way that we're going to drive everything forward. So please help us to help you. Get involved with the organization, get signed up to the registry, tell your doctors about EDS echo, the medical professionals directory, and work together with us to change things for our community. And on that, I'm going to hand over to Dr. Hakim.
Thank you very much, Lara. So I'm going to do a whistle-stop tour through the key elements of, that make up Ehlers-Danlos syndrome. But I'd like to just start by reminding you or alerting you to the huge number of webinars that we have available on the Ehlers-Danlos website, ehlers-danlos.com/webinars, for patients and equally for professionals, a wealth of information that you can look through in your own time that talks about both the clinical and basic science elements of EDS. But I think more importantly, there's loads of information on there about healthcare, self-management. So I really encourage you to take a look at those web pages. In addition to the webinars, there's a huge amount of other information, static information documents that you can download to help you guide yourself through the diagnosis and the management of the different elements of Ehlers-Danlos syndrome. So really do take a look. One of those things that you'll find coming very shortly, I only did the webinar last week, and so it's about to be published on our website, is something I did for May Awareness, EDS HSD 101. The slides that I'm showing you today are part of that, but this was a whole program for 60 minutes. And so I hope it's packed full of pearls, and I really encourage you to take a look at it. Similarly, given that we are thinking about rare diseases with your group today, there's a great webinar from Professor Francisca Malfay, rheumatologist in Ghent, where she talks about the rarer types of Ehlers-Danlos syndrome, how to recognise them and manage them. And I'm going to give you a flavour of that now, but again, she goes into it in considerable more detail. And again, I encourage you to take a look at that. So when we're talking about EDS, when I'm thinking about EDS, I'm reminding myself that it's a connective tissue disorder, and that essentially, although the problems are protean, it's arising because of changes in genes that alter the structure or the production or the processing of collagen and the proteins that interact with collagen. And it's important for us to remember that latter point, that it isn't just about collagen genes now. We're very much aware so much more of the biology of the proteins that make up the structures in the body and their interactions with collagen. And so the consequence of these kinds of changes are that you develop musculoskeletal issues. And this is not just the joint hypermobility and instability, and I'll be talking to you about a couple of those other issues in a moment to highlight the point. Skin abnormalities and other structural tissue concerns. And of course, these are all associated with genetic abnormalities in the rarer types of EDS, though the genetics for hypermobile EDS are yet to be identified, hence the importance of the hEDS study that Lara was talking about. To visualize that, then, I like to think about a Venn diagram and think about where in my patient's presentation with their problems each of the different issues might sit. And I think you can start to see from this simple Venn diagram that you can start to place lots of the musculoskeletal issues in one area, the skin issues in another, and all of the other connective tissue issues in the third. And they all overlap with each other, and the vast majority of our patients will effectively have a mixture of all of these and sort of sit in the middle of that Venn diagram to varying degrees, with varying amounts of each of these different elements making up their symptoms and the findings when they're assessed clinically. The other thing we have to remember, though, is it's not just about these structural proteins and the impact that they have on the body's actual physical structure. There are a number of other conditions that add complexity to the presentation of Ehlers-Danlos syndrome. But it's also important to just bear in mind that these are not diagnostic of Ehlers-Danlos syndrome. We can see these sorts of concerns in other conditions. And so whilst we recognise that there appears to be a greater prevalence in EDS and also in the hypermobility spectrum disorder, we can't say that they are primarily features that are diagnostic of the condition. And the key things that we're looking for that seem to be most prevalent in our patients are chronic musculoskeletal pain, chronic physical and cognitive fatigue. So by cognitive fatigue, I mean the brain fog that everybody will recognise that experiences this kind of sort of mental fatigue. Mental health concerns are very important, and we recognise that not only can they arise because of an underlying tendency towards mental health issues such as anxiety and depression, or possibly even a neurodevelopmental disorder like ADHD, but also can arise because of the concerns that an individual has about the complexity of all of their symptoms, the impact this is having on their life and the quality of their life. And concerns that they're either not being assessed properly or managed effectively, and it's all very challenging for them. And I think we're beginning to recognise more and more that whole process of having to try and understand the symptoms, feel that they're being assessed and feel that they're being managed, that you're being cared for, can actually lead to something called post-traumatic stress disorder, when you really feel that you're not getting on top, or your clinicians are not getting on top of your concerns. And autonomic dysfunction also seems to be a really common issue that drives a lot of the severity of the symptoms in patients. So cardiovascular, things like POTS, which you will have heard of, I think, orthostatic hypotension, the gastrointestinal symptoms such as severe bloating, changing from constipation to diarrhea. bladder issues with instability, irritability in the bladder, temperature regulation, the number of patients that tell me that they just cannot regulate between hot and cold. And there are a number of other concerns, and this is why we talk about joining the dots. If there are multiple issues, think connective tissues. So gynecologically, very heavy bleeding during periods, also significant pain is that bit more common in EDS. The control of these with things like progesterone hormones is more complicated because progesterone can make tissues more stretchy and give you more musculoskeletal symptoms than you had before if you're intolerant to the treatments. Headaches, including migraine, neuropathies and nerve problems, which can arise because of entrapment of nerves, stretching of nerves. And we've also come to identify the small fibre sensory neuropathy that leads to numbness, tingling, all sorts of unusual sensations in the hands and feet, and similarly pain. Allergy and immunology disorders are coming to the fore, and we need to do a lot more work to understand these, but we begin to recognise now the link, particularly between bowel and bladder problems and mast cell accumulation, histamine release, and essentially multiple allergic responses. So lots to also consider, but are not part of the diagnosis. So I mentioned that we recognise a number of rarer types, and we recognise these in part by their clinical presentation, but also primarily by the fact that we have got genetic markers for them. This is a beautiful slide that was produced by Amberger and colleagues a year or so ago. Just as this slide was being produced, an additional gene was found. So there's another diagnosis of EDS that needs to be added to the flower. But here you see the 13 types that we describe in the 2017 criteria based on their clinical presentation and their genes. I'm not going to go through each one of these in detail because time would allow me to do it, but I think it demonstrates to everybody the complexity of this and the range of different types of disorder that can arise. The most common of all of the types is the hypermobile type. We don't talk about the hypermobile type as the more rare types. All the others are the more rare types, ranging from the classical and the vascular, which are perhaps the most recognized, all the way through to much more rare variants, such as the spondylodysplastic or the brittle cornea. Each one of them now has identified genetic abnormalities that lead to collagen or other structural protein abnormalities. These are described very nicely in a talk on genetics by Peter Byers. Again, I would encourage you to take a look and remind you to have a look at Francisco Malfe's talk. Just coming back then to this principle of the different amounts of problem that can arise, musculoskeletal versus skin versus connective tissue. Let's just work through those together to think about EDS in a bit more context. So the findings that are very common pretty much in all types of EDS and found to varying degrees are the presence of the joint hypermobility, joint instability, and these are subluxations where the joint feels like it's slightly slipping and then slips back into place. I think this is the sensation that people are describing when they talk about clicking and clonking of their joints. And then the frank dislocations where the joint literally comes right out of its joint. Most patients, I would say, are experiencing subluxations. A smaller number, it's very clear that they're dislocating their joints. The injury to ligaments and tendons and soft tissues that arises because of this instability in the wider range of movement. There's also good evidence now on a reduced awareness of position sense, something called proprioception, your body's subconscious awareness of where it is. This is why people often feel they're a bit clumsy. Pain, both in the joints, the muscles and the nerves, so arthralgia, myalgia and neuralgia. Physical fatigue that I described earlier. And of course, there may be a family history of very similar concerns, and all of these things can lead to changes in movement patterns, changes in physical function, starts cause limitation in function. In the rarer types, though, there are other things that we need to look out for. one of the issues that we're always looking for is a very severe curvature of the spine. So not a mild curve, because that's quite common in the general population. And you might find a mild curve in, say, for example, the hypermobile variant of EDS. But really marked scoliosis, the S shape to the spine, or a kyphosis. This is like the dowager's hump, the curve of kyphosis. There can be very abnormal shape to joints. We call this dysplasia. The hip is perhaps the most common example of this, hip dysplasia. Dislocations from birth, so congenital hip dislocations. Clubfoot, changes in the skull and facial bone structures and the facial features can all occur to some degree in the rarer types, and also short stature. So you can begin to see from this list how it looks very different from the hypermobile list, where pretty much stature is essentially normal unless there's a Marfanoid body shape. Other things that you find in the rarer types as well are things like very low muscle tone from birth, congenital hypotonia, tightening of the tissues, so the opposite of stretchiness, congenital contractures, low bone density and spontaneous fractures in the rarer types, which fortunately is very rare even though the bone density is low. And again, a family history of these concerns. So this is the breadth of things that we're looking for on the musculoskeletal side. And you can see the different types of layers to the severity and complexity to the presentation. The skin equally has a similar sort of picture. You can find very common things in EDS that are found to varying degrees: the stretchiness, the softness, stretch marks from adolescence after you've excluded other causes for this, including rapid weight gain and rapid weight loss. The thin scars that we call papyraceous scars. These things called pysogenic papules, which I'll show you a picture of in a moment. And again, family history of these concerns. Now, we also recognize things like ease of bruising, varicose veins, and slow wound healing. These aren't in most of the criteria, other than varicose veins in the vascular form of EDS, because it's quite difficult to demonstrate that they are directly causal in EDS. They may well be a consequence of the thinner skin and the more stretchy skin, as opposed to a problem in their own right. In the rarer types, the skin may be much, much more excessively stretchy, and it may even be sagging or redundant skin. Very severe atrophic scars. I'll show you some examples. And then these very unusual pseudotumors, molluscoid pseudotumors, and subcutaneous spheroids, these unusual lumps and bumps that one sees underneath the scars, underneath the atrophic scars. Again, more typical of the rarer types, very severe bruising and blood clots underneath the skin, hematomas. Severe varicose veins, usually in both legs, typical of vascular EDS. Translucent or very thin skin, ease of tearing or sloughing of the skin, poor wound healing, the wound splitting, and again, a very strong family history of similar concerns. And these are the sorts of things we're looking for then in clinic: the stretchiness that I've put a ring around here, the papyraceous scars. You can see one across the knee there. The one above it is just a scar that appeared spontaneously on the skin. Here now you can see the atrophic scars, much more marked than a papyraceous scar, stained almost with hemosiderin from blood that's been released underneath the scar, looking very much like a very aged skin in somebody who's otherwise a young person. Pysogenic papules on the heels, these fat pads that are just protruding through the skin tissue. And then over on the right-hand side, if you were able to feel these little lumps, they would be somewhat tender and they'd be firm and they'd be just underneath the skin, making the skin feel nodular, but the skin also feeling quite rough from the atrophic scarring. Stretch marks in unusual places across the front of the chest, across the back, down the backs of the knees, sometimes down the sides of the arms. We have to make sure that we've excluded other causes because there are other causes, including weight gain and excess steroids. But for the vast majority of my patients, these have arisen over time since early adolescence. And bruising, again, we have to think of causes for this, but bruising does give us clues. And it's important for us to think about whether there are other underlying reasons why somebody might be bruising. This includes abnormalities of platelet clotting and also trauma. And the skin can be very thin. This is a picture of somebody who has vascular EDS. You can see the veins, the fine veins and the tissue underneath it. And if you were to feel it, it'd be extremely thin. So again, with the skin, we get different degrees of these features to differing severities that relate to the different types of EDS within the group. What about the other tissues? So we recognize commonly across the EDS group that the eyes, there can be problems, short, long-sighted, astigmatism, double vision, dental crowding and gum disease, hernias, gastrointestinal slow transit, so it feels like the tummy's full and won't empty, or very constipated and the bowel takes a long time to empty, rectal prolapse, and urogynecological prolapse, so bladder and uterus, and also family history of these things. So these are the more common structural issues that we see from the other connective tissues. But in the rarer types, we see some very unusual additional issues, such as corneal scarring. Brittle cornea syndrome is a good example. Severe gum disease, the periodontal type of Ehlers-Danlos syndrome is a good example. And you'll probably be familiar with the life-threatening issues in the rarer types, such as aneurysms, arterial dissections, ruptures. This is very typical of the vascular form of EDS, but we do see it to a degree in some of the other rarer types. Bowel and visceral organ rupture, including the uterus in pregnancy, a big risk at the end of the third trimester for vascular EDS mothers. Collapse of the lung, aortic root dilatation. And here, if we see this, we have to start thinking about other conditions like Marfan syndrome. We have to remind ourselves that there are many conditions that have got EDS-like features to them that are not EDS. So there we are. So there's a sort of quick run through the kind of picture that we're looking for and weighing up the different types of severity of presentation, and then going on to think about, having assessed the clinical presentation, whether there is sufficient evidence or guidance from the criteria as to whether we should start to do the genetic tests to explore and complete the diagnosis. But the hypermobile type and the hypermobility spectrum disorder are a potpourri of very mild features for which there actually isn't a diagnostic test. It is entirely a clinical diagnosis, and there as yet are no genetic markers. So I'm just going to come on to this now, and I'm going to start with a little history lesson, which I have to say, given that I'm talking to everybody from South Africa, includes Professor Peter Byton in the history. As you'd absolutely expect, Professor of Genetics in South Africa. If you look over on the left-hand side of your screen to the green icons, the story in rheumatology or musculoskeletal medicine starts in the 1960s with the work of Kirk, Ansell and Bywaters, who described the presence of hypermobility, joint instability, injury and pain. And they call this hypermobility syndrome. As you move forward then over the ensuing couple of decades, colleagues within rheumatology were realizing that there were more features to this than just the joint hypermobility. And that's where the features recognizing the presence of a Marfanoid body habitus, the soft tissue injuries and various other descriptors led to the use of the diagnostic criteria for benign joint hypermobility syndrome. Moving through the 90s into the early 20s, the B for benign got dropped because people began to realize that really there wasn't very much benign about this condition in terms of the way it affected people. And so the term joint hypermobility syndrome was coined. Let's go over to the other side of the screen now, though, on the right-hand side, and look at the red icons. And here in the 1960s, again around about the same time, the awareness that there was of Ehlers-Danlos syndrome as a group of conditions had led to the classification under Peter Byton and colleagues of 5 types. But they recognized that one of the types was actually perhaps more common and more mild in its presentation, and that this type they decided to call EDS, benign hypermobility type, starting to sound familiar, I suspect. And that's where that term arose. But over time, as the genetics became more clear for some of these conditions, and the Villefranche criteria were published in the 1990s, the term EDS3 was coined for that group because there wasn't a genetic marker. And this is where we then got type 1 and type 2 for the classical, type 4 for the vascular, etc., etc. Over time, the number terminology was changed to nomenclature, so that by the late 1990s, early 20s, we were calling it EDS hypermobile type. Now, there's a story that comes from rheumatology on one side and a story that comes from genetics and dermatology on the other side. And it became clear that actually joint hypermobility syndrome had a group of patients in it that were very, very similar, if not identical, to the patients that are diagnosed as hypermobile EDS. And so terminology started to arise along the lines of, this patient has JHS synonymous with hypermobile Ehlers-Danlos syndrome. Now, this was right for a proportion of patients, but not every patient with joint hypermobility syndrome has sufficient features to describe them as having the hypermobile variant of Ehlers-Danlos syndrome. And to give you an example of this, you could be given a diagnosis of joint hypermobility syndrome by fulfilling the two leading criteria, which is hypermobility and widespread pain, and have none of those other structural features that I was describing earlier. And so therefore would never really appear to be somebody with EDS. So if you're going to use a term JHS/EDS hypermobile type, it actually either overexpresses the presence of the EDS or doesn't recognize that there's a group of patients with the joint hypermobility syndrome that don't have EDS. And that led to a lot of confusion. This is what happened. This is a patient of mine who could have told you this story. You have hypermobility and you've had an injury, but you don't have a syndrome. Okay. Then told, well, actually, no, you have joint hypermobility syndrome. Then told, well, no, actually, you don't. You have Ehlers-Danlos syndrome hypermobile type. But because of that, actually, what we call it now is JHS EDS hypermobile type. And this is a really common story that a lot of my patients would share with me. And it's clearly not very helpful. The terminology is very confusing. So the aim from the 2017 criteria was to merge the criteria for joint hypermobility syndrome and EDS hypermobile type into one descriptor for a condition that was recognizable in this group. And that's how we ended up with the 2017 criteria for hypermobile EDS. Now, the issue with that is that if you fulfill the criteria, that's fine. But if you have problems that are akin to it, but you don't fulfill the criteria, then in effect, you remain on the left-hand side of this image. I put the colored spectrum bar going from left to right. If you're on the right-hand side and you meet the criteria, you have a diagnosis. If you're on the left-hand side, then there was no terminology for this. And so we discussed this in detail. And this decision came that we should describe these other patients that don't fulfill the criteria as having hypermobility spectrum disorder. So now when we look at this, comparing HSD and hypermobile EDS, our HSD patients can have generalized, widespread hypermobility, or their hypermobility can be localized, or it can be peripheral to their small joints. This is then associated in those joints with musculoskeletal structural concerns, the joint instability, the straining and the soft tissue injury, and the pain that we recognize, which may be in the joint, around the joint, or neuropathic around the joint. Compare that then with hypermobile EDS. They will have exactly the same set of those musculoskeletal symptoms as part of their presentation in the presence of generalized joint hypermobility. But they also have these milder variants of the skin pathology that we see in EDS, the tissue fragilities that we see in EDS, but not those that we see in the rarer types, and the marfanoid body shape. And that's how one can see the difference between these patients in terms of their phenotypes. But they can have very similar presentations from a musculoskeletal point of view. Really important, though, is that they both appear as groups to have issues with the related conditions that I described back at the beginning. So this is how we now see the zebra spectrum, if you like, between hypermobility spectrum disorder, hypermobile EDS, and the rarer types. That if you start over on the left-hand side, you may be hypermobile and completely well with nothing else going on, life is fine. But if you develop various musculoskeletal concerns that add insult to injury, you start to look like somebody with hypermobility spectrum disorder. However, if you have some of the more mild or minor variants of the skin and the tissue abnormalities, you would fulfill the criteria for hypermobile EDS. If those phenotypes were more severe, and if there was an abnormal genetic finding, you would fulfill the criteria according to the features that have been found and the gene that's been found of one of the rarer types. And this is the new structure for considering the diagnosis. So I hope that helps, but I completely recognize that that can be a terrible puzzle for people who have never come anywhere near any of this. And the best puzzle I could think of is the Rubik's Cube. I can't do the Rubik's Cube, but I think I've got a bit better at diagnosing people with different types of EDS. And so one completely appreciates that this can be very difficult for individuals with EDS, for their relatives, caregivers, friends, for doctors, therapists, insurers, health commissioners to really understand. And one of the things we really want to do is try and help people to just get much, much more familiar with the terminology and understand more about how one makes a diagnosis and the opportunities that there are thereafter for actually dealing with the issues that can arise. So we've been doing a huge amount of work, committed in a number of ways in the Ehlers-Danlos Society to spreading the word and teaching. Conferences, managing social media, webinars like this one today, website information, publications, research, and we also have the strength of our international collaboration of experts and lay members. But we recognise that healthcare constraints exist both for clinicians and for our patients. And our aim is to continue to find ways to build confidence for everyone in terms of assessment, diagnosis, management of the general aspects of care, better access to expert opinion, and we also recognise that within and even between nations there's huge variation in access to this expertise. So we've been thinking about how we build, bridge these gaps by other means than the conferences and various other things we've been doing. And I just want to quickly introduce to you before I close Project ECHO and EDS ECHO as a means for doing this. So EDS ECHO you can read about in detail, so that's a bit blurred, that page, but the main thing I'd like you to take note of is that if you go to our website /ECHO, there's a huge amount of information about what Project ECHO actually is and how we are using this resource for EDS to help train clinicians everywhere in the world. The aim of this is that specialists who are at the top of that box image there are able to communicate in exactly the same way that I am with you, and in a moment you with us, to share our knowledge with other more local primary care teams or local sort of specialists who don't have an expertise, so that they are better able to manage their own patients in their own communities. So this isn't telemedicine, this is tele-mentoring, this is passing the knowledge around the system, all teach, all learn. And the idea then is that more patients are given the support that they need from their local teams and don't necessarily have to access the experts who are few and far between and significant distance from them. So we've started initially with a hub in Baltimore in the USA and one in London, which I run. And these little spikes shooting out are not an advert for British Airways or United Airlines, but they could be. But just trying to demonstrate to you that we really have quite wide coverage of people that are joining us at the moment. However, our aspiration really is to, our aspiration is, I've lost a slide, is to have many, many more of these hubs all over the place. Now, I'm a bit disappointed I've lost that extra slide, because I had a lovely little blob right down somewhere near, I think, Johannesburg or Cape Town for the whole of South Africa. But the more of these we spread around the world as hubs that are able to network with each other, the more people will have access to the expertise. So do take a look at EDS Echo, and I'd really encourage you, there's a flyer that you can click on and print out. I'd really encourage you to take that to your clinicians and ask them if they're interested in either joining one of the programs that we've already set up, or even as a network, thinking about their own local or regional network in your country. Lara, back to you.
Let me unmute myself. Thank you. Yes, you can see here all the different ways you can reach out to us as an organisation. You can reach out also to me directly if you have any questions. But I really would encourage the 3 things that you do following this is, number 1, please tell your professionals to make sure that they're on our registry, or get the terminology not confusing, our medical directory. Please make sure that you are listed on our global registry, and please tell as many professionals as you can about EDS Echo, so that we can really try and get as many people from around the world signed up to that. I think we have a question in there. Kelly, I don't know if you want to do questions.
Yeah, absolutely. So, so I have a question before I jump to Corne's question, and it's really in light of the fact that we are obviously such a developing country in terms of healthcare in so many ways. If you had to focus on one thing from a diagnostic perspective that needs to be improved, what would it be?
So I think even in my own country, the perspective would be to recognize that there are multiple issues, that you cannot do this in a kind of singular way. I think too much of medicine has become broken down into individual specialties and then subspecialties within them. So encouraging people to listen to the breadth of the story and begin to realize that these things actually join up gives you a fighting chance of realizing that you have a syndrome in front of you. And I think once you realize that, then you are able to, it starts to unfold. It always amazes me how even for many patients actually alert themselves to the fact they have a diagnosis before their doctor does. But if you just take the diagnostic criteria checklist and you just work through it, you can see how somebody actually, how the diagnosis evolves and how the related disorders can be identified. So yeah, there's a long answer for allowing yourself to listen to the whole story and think about it as a syndrome rather than each thing being an isolated problem.
Yeah.
So I would just add to that. The only thing I would add to that is also just going back to what I said earlier, that remembering that there is no such thing as an EDS expert. And I think that's important for both medical professionals to remember, but also patients. When people are like, there's no EDS expert in my country, that's okay. There doesn't need to be one. I always think about, from my own experience, my cardiologist that looks after my POTS long term, I was the first EDS patient he'd ever met before, and he has presented now at our EDS conferences because he, on his own back, was like, this is really interesting and I'm going to learn more about it. And he now is known as a local expert, knowing about what EDS is. And that's all it takes, someone to be willing to learn about it, treat the patient, look at the whole, multi-systemic nature of it, and make people feel better. I mean, that's really what this is about, and you don't need to be an EDS expert to do that. So one of the
things that I talk about with my colleagues who've got to that stage in their learning to become more experts and more generally able to manage, is that they still need that kind of subspecialty expertise. And so So over time, clinicians really need to be encouraged to build networks, which is why I think the ECHO program helps. But I haven't come across anywhere in the world where people feel really confident about their resource without there being a multidisciplinary team that's talking to itself about all of the patients and managing the complexities together. I know an awful lot about Ehlers-Danlos syndrome, but I probably manage, from a care point of view, less than 10% of the issues that I'm aware of. So I kind of almost act, if you like, as the primary care or lead coordinating clinician with the expertise all around me in the network. So that's the other element to this. You cannot, once you've learned about this, you cannot just do it by yourself.
Yeah, I think that is something that, the multidisciplinary care, with South Africa having really a dual access system where we've got 85% of the population accessing the state sector, which has really good referencing, and they really do a lot of multidisciplinary work really well together. But to get to one of those tertiary centers is very difficult. And then on the other side, you've got 15% of the population accessing private healthcare. And the multidisciplinary framework in the private sector is actually really minimalistic, in the sense that these doctors are often practicing at various hospitals, and they don't actually, across disciplines, they don't have a lot of contact time with each other. So if you're a cardiologist, chances of you speaking to the rheumatologist are minimal, particularly if they're at another hospital. So patients are traveling to various hospitals for their various appointments, and it's fragmented the managed care in a big way.
Yeah.
And our advice to patients is always, the key questions often, who's the best person to be my primary care doctor? And there's not always the right answer to that. It's about finding the one doctor who you have a good match with,
right,
and who is willing to take responsibility to share the communication amongst the rest of the clinical team.
Yeah.
And I think we are doing some work on creating a simple sort of patient diagnostic diary that patients carry on them, almost like a vaccination card, which patients can then use to travel between their doctors, so that the information is kept current, and that there's always a reference, even if it's 2 lines, to the most recent appointment. It's better than what the existing communication is. So we've, and it's a really simple thing, having a booklet, but it's also very, very necessary to make sure that the communication's key. So thanks so much. I see the one question that has come through is related to Epstein-Barr virus. And she's asked that she's read a study about Epstein-Barr, and that it plays a role in EDS. She's had Epstein-Barr at the age of 22. In your experience, has that been quite prominent?
No, not at all in my experience. I'm trying to think of the context here. I'm not sure if the question, if the person asking the question is asking whether Epstein-Barr has caused the Ehlers-Danlos syndrome. That I cannot think of a mechanism whereby that would be the case. But I am very aware of many types of situations where something else medical has happened to somebody who has silent Ehlers-Danlos syndrome. We have to remember that the diagnosis only gets made when you present somewhere with a set of symptoms, because all these structural issues are going to be around and you may not be aware of them. There are well people with various types of, particularly of hypermobile EDS in the community that we don't see. But if you have another condition that maybe has an impact on your general well-being, it might trigger an autonomic disorder, it might trigger fatigue, etc., etc. That set of symptoms may well then take you to a clinician and expose the fact that you also have these other features, and so they layer on each other rather than the infection being the cause of the EDS. And I've seen that a couple of times, and I think it's really important in the context of understanding why people present with their symptoms. which is why you need a really broad church of knowledge around medicine. This could be a kind of situation, for example, where it would be inappropriate to simply assume that fatigue from a chronic infection, for example, was the chronic fatigue syndrome or fatigue from EDS, because that's what you physically found, without realizing that that actually the presentation is the side effects of the infection. So when I meet with people for the first time who have previously been absolutely well, I have to always consider what changed, what happened that has suddenly led to these sets of symptoms. Can I directly relate that to the diagnosis of EDS, or am I looking at something that's sitting in parallel with it that's exposed the presence of the EDS? Does that make sense?
Yeah, it does. I suppose we're all made genetically, and you've always got a predisposition to certain things, and I think that it's also it's a massive misnomer in terms of actually treating patients when you've got a rare condition, because very often if you land up in hospital for something, the first thing is, okay, it must be part of the condition that we know nothing about.
Mm-hmm.
And very often it's actually, you're really just developing laryngitis or something, and they've put it down to it has got to be part of your rare condition. So
exactly, it's a really important point, Kelly. It's so important.
I think from a patient, and having a good understanding of what your condition is and what's necessary.
When I talk to my patients about that kind of problem, to try and remind them to always remind themselves that it isn't just about the EDS, and remind their doctors that it isn't just about the EDS. I say, if you happen to go into your doctor with your right ear falling off, don't let them tell you that it's due to your EDS. Okay, something else odd has just happened to you. Now that's extremely silly, but it reminds people that not everything is about your condition. And I think this happens certainly in the world of musculoskeletal medicine. This happens in fibromyalgia as well. Once you have a diagnosis of fibromyalgia, then everything, regardless of what that problem is somehow related to it, without thinking about the whole breadth of issues and diagnoses and diseases that it could actually be. And that's a terrible risk for the patient and a mistake from the clinician.
Okay, Ashley's asked, she said she would really like for there to be protocols and diagnosis and treatment plans, because many of the patients are offered various treatments, and I suppose, again, we have a big problem with that in South Africa, where what you get on one side in private is very different to what's available in state, from a diagnostic perspective and an overall treatment perspective. So maybe that is something that we can also work on educating, to make sure that appropriate international guidelines are actually implemented. And then, is it worth running a genetic profile? Sorry, Lara, carry on.
I was just going to say the pathway work will hopefully answer that, and I think the more that we work with organisations on the ground to make sure that works locally, then the better it will be, for sure.
Yeah.
And Kelly, I think that there are kind of sort of three different types of guidance. There's there are the standard treatments that we know should be applicable for anybody, regardless. So we use things like neuropathic painkillers and other sorts of painkillers because that's what we do in musculoskeletal medicine. It doesn't matter about which diagnosis it is. And then from that core, there are the subtle tweaks, variations in treatment. So physical therapies is a good example of that, how they need to be adjusted, changed because of the presence of the musculoskeletal issues in EDS. And then there are the more complex issues. And I think we've begun to realize that each one of those complex issues probably needs a set of guidelines. And so I can immediately think of the gastrointestinal complications as one set, including gastrointestinal failure, the management of the unstable neck and cervicomedullary syndrome, the neurological problems, needs a set of guidelines because the management is different. And there are a whole host of them, and we're exploring all of those with the Pathway Group at the moment.
Okay. Part of Ashley's question is that she fits a lot of the criteria in terms of hip dysplasia, mitral and tricuspid valve prolapses, POTS, gastroparesis. She's asking, is it worth running a genetic profile if I definitely fit the hEDS, well, hypermobility EDS? Lara, I don't know if you want to maybe refer back to the hEDS study.
Yeah, so I think that there's a couple of things to say here. I think people would quite often would like the peace of mind of being offered a genetic test and it's not freely being given up, and I do think that is globally an issue. I think that currently we don't know what the genetic cause is behind hypermobile EDS, and so if that's the diagnosis, I would say at this stage there's no real point in having a genetic workup until we know more. But then if a rarer type is suspected, that's when you would push for a genetic test now. I do hope that within the next 3 years we're going to know a lot more about the genetics behind hypermobile EDS. But I don't think it will be one. I think if you kind of imagine a big bucket full of hypermobile EDS people and HSD people, and what will come out of it is that either we'll learn more about the more rarer types, or there'll be one that's, accounts for much more prevalence amongst that group. But really, we're not going to know until we really start to do this and understand it, and do variants of unknown significance have more significance, and all these questions that up until this time we haven't been able to answer. So I think it's if your diagnosis is hypermobile EDS, there's no concern about it being another type or indeed another condition. I would say hold off until we have more answers from the HEDS study.
Yeah. There's also been another question, and it was actually something that I wanted to ask as well, with regards to long-term pain management. How critical is pain management in South Africa once we have limited long-term pain management and access to pain medications in the state sector? And there is quite a lot of work being done from a palliative care perspective to, in terms of managing pain control, but there's a lot of work to be done in that space. From your perspective, how critical is focusing on long-term pain management in terms of managing day-to-day symptoms?
Yeah, well, I think it's right up there. It's up there because it interacts with mental health, it interacts with autonomics, all sorts of things. The challenge, though, is pain management can mean different things to different people, including different clinicians. But if you think about the totality of all of the things that we can use, medicines, a lot of the time people find that the medicines are just not very effective, and they go through escalating doses, and then they run into side effects without getting much relief. That's a challenge for us. I don't think we've got optimal medicines. We just use the ones that we have available, right? So that's an area that needs exploring, but there is maybe an opportunity with some medicines to bring some of the pain down, but not necessarily get it completely under control. Some people find that they have a terrible intolerance to medicines as well, that they just can't even take the standard doses, just doesn't agree with them. So relying on medicines only is not the answer. Then there are the physical treatments, which we believe have a really important part to play. Now, these may not necessarily be bringing the pain down by a huge amount, but they should be improving function and therefore quality of life, ability to undertake day-to-day activities, etc., in a less painful way. And then obviously, all the sort of cognitive therapy, relaxation, distraction kinds of techniques that also bring in things like clinical psychology, sort of management of well-being despite symptoms. So there's a plethora of those things, and I deliberately didn't mention the interventional stuff, which is to stick injections in things and see if it takes the pain away. That can have a place in the isolated kind of mechanical issues that people have, but not really, I think, perhaps more as part of the chronic pain management. I see it as a critical part of having to get the patient's care under control. If I had to list the top 3 things that I think matter in improving overall well-being in general in our patients, it's their pain management, management of anything like autonomics or gastrointestinal that might be triggering fatigue, and their mental health well-being.
Yeah.
Those top 3.
I always say with a strong mind you can do pretty much anything, but when your mind's broken, it's not so easy.
Yeah.
Wow, thank you so much. I'm not sure if there are any other questions. Lara, this will be circulated to our healthcare professionals as well, and I'm sure that there'll be lots of questions that pop up from them from a practicality perspective. So I will try collate those and send those through to you, or send letters of introduction, emails of introduction, to make sure that they can get as much as the information that they need to better understand. Another question has come through regarding GI symptoms. A lot of doctors don't always connect them. Even with all the data available, I've had gastroparesis. I have a G-tube, also esophagus abnormalities. I've started oral again, and I'm on TPN for now, but still rely on both tubes. Is it possible to be tube-free, or is it this likely to be long-term? I suppose difficult question to answer without ever having seen the patient, but
yeah, that is a difficult question to answer. But we've had these sorts of questions coming up even within our ECHO network. And one of the things that we think we can do is link clinicians with other clinicians to discuss complex cases. This sounds like a complex problem for this individual. And I would have thought that if she spoke to her gastroenterologist or whomever is looking after her, and they wanted some advice, she could give them permission to contact me, and I can contact somebody like Professor Kazim Aziz and link them up so that they can talk through how best to support her. That's how this network works.
Absolutely, and I think that that's what makes webinars like this just so valuable, is to let everybody know that they're not alone. And even if it's just asking someone else who might have the very, very practical advice on how to improve the problem, that is essentially what we need. We are all in this together. So, wow, thanks so much for such an informative evening. I think I've learned a lot. I'm sure everybody that's tuned in has, and everybody that will listen to this going forward. So we make these webinars available to newly diagnosed patients. We record them and keep them on file for a patient that gets diagnosed a month or 2 from now as well, so that they've also got access to the information. And really, we'll do everything that we can from our side to make sure that we encourage everybody to register on the registries. We'll also include the links to our doctors and healthcare professionals as well. So, wow, thank you so very much. We really, really appreciate your time, and we look very forward to hopefully having you guys. There is one more question that I'd like to ask on the poll, and this is with regards to having a conference in South Africa. So we'd quickly like to hear from everybody, but we will also make this available within our EDS community in South Africa to try to determine who would really like to see a conference in South Africa. I know we all will, and where that would be most appropriate. So if you haven't yet, please, if you could answer what you think would be the best. And hopefully we look forward to having you guys out here really sooner rather than later for a meeting. I can see Johannesburg's coming up as a favorite already, which is great for me because it's easy. But yeah, we hope to have you guys around relatively soon for that.
Absolutely.
So Lara, Dr. Hakim, thank you so much again.
Thank you, Kelly. Goodbye.
Thanks so much.
Chatting soon. Thanks. Cheers. Bye.
Thanks, Kelly. You're a star. Thank you. Bye-bye.
Bye.
Bye.